am.
All right, perfect. So I will introduce myself first. I'm Maureen O'Connell, one of the physical therapists here at Physio Partners. We both specialize in pelvic floor PT. In addition to that, I enjoy treating chronic pain of any sort, whether it's chronic pelvic pain, chronic back pain, neck pain, all of that. I have a special interest in, as well as treating runners, whether it's someone who is postpartum wanting to return to running, or someone who is, maybe never been pregnant or never had an issue, males, females, any runner or endurance athletes. Those are my, I also treat lymphedema of the extremities, upper and lower. So there's a little tie-in later with the lymphedema, but very brief. Elena?
Yeah, so I'm Elena Heron. I also am one of the pelvic floor therapists, but I do orthopedic as well. My clinical interests, though, are pelvic floor dysfunction, chronic pain, just as Maureen said, kind of chronic pain of any sort as well, and then digestive disorders. Both Maureen and I both have had coursework through our Herman Wallace Pelvic Rehab Institute. So that's been a really good resource for us to get even more experience and kind of education on the pelvic floor in general.
Yes. All right. So we will move to the next. So a brief overview of the pelvic floor function. It can be summed up with the 5 S's. So we have the sphincter control, which the muscles help to control the sphincters of the urethra, the vagina, and the rectum. We have sexual support. The muscles provide a support for the urogenital triangle, which you will see in the next slide, and also help aid in some proprioception and some sensation. Support, the muscles act as a sling at the base of the pelvis to help support our pelvic organs. They also provide stability in through the form of, as these are a very important part of our core, they help stabilize the bony pelvis as well as the abdomen and the back. Finally, the sump pump action, which is where it ties into that lymphedema a little bit. The muscles help to pump circulation and lymph fluid throughout the pelvis, as our muscles do elsewhere. There is a lot of, we do have a lot of lymph nodes in through the hips and in through the pelvic region. So that is another main function of these muscles. Here's a brief overview of some of the muscles. And the urogenital triangle, you can see, is really those green muscles, the light green coming through the middle, and then the dark green coming up top. I'll go through here. Okay, so you can see how these are all muscles in through here, male pelvis versus female pelvis, and how those muscles can aid in support. Those are the superficial. We have some deeper ones back here, as well as providing the support for the urogenital triangle. All right, as I mentioned before, the pelvic floor is part of your core. If we think of this as a canister, everyone has their own definition. Sometimes it comes all the way up to the neck. For our purposes, we'll say the top of the canister is the diaphragm. The bottom of the canister is the pelvic floor. We have our abdominal muscles as well, and then our multifidus, muscles in through the back. These are some main muscles of the core that help to give us support and control the abdomen as well as the pelvis. The main definition of the core, however, is any muscle that attaches to the bony pelvis. So there are a lot of muscles. It includes all of our hip musculature. These are some of the main players, and you can see why the pelvic floor is a big part of our core and core stability. Moving into some mechanics of how the diaphragm and the pelvic floor play off of each other in managing that pressure throughout your canister. When you take a deep breath in, the diaphragm will extend into the abdomen, and you'll get a reflexive pelvic floor lengthening if we have an effective excursion of the diaphragm and breath pattern. Then on the recoil, as the diaphragm comes back up, we'll have a pelvic floor contraction with it to meet the demands of the breath.
All right, so I'm going to talk a little bit about some of the diagnoses that we treat I just want to preface this that this is not a comprehensive list. There's a lot of other things that we treat. These are just the most common. And we will go more into depth into a lot of these as the presentation goes on. But just to start, urinary incontinence. So there are a lot of different types of urinary incontinence, but in general, incontinence is essentially a leakage, either of urine, feces, things like that. So urinary incontinence is a leakage of urine. Pelvic pain, so this can be caused by a number of different things. If you're looking here at, a lot of people are wondering what's dyspareunia. That is pain with intercourse. So oftentimes that pelvic pain can affect just about everything. The pelvic organ prolapse, so we'll talk a little bit more about that later, but a prolapse is essentially a descent or a drop of the organs in your pelvis. So those names might look a little funny, but I promise we'll go more into depth in them later. I just won't go into each one right now. And then bowel disorders, there's the fecal incontinence, which is where I was talking about incontinence is the leakage. So in this case, it's leakage of feces. Then constipation and disordered defecation. Next slide, please. Thank you. So we also do pregnancy and postpartum. These are two really big pieces that we treat as well. With pregnancy, there's a lot of different pain in different areas throughout the body as your body is really changing so much. We have a lot of laxity that comes into our joints and into our ligaments. So then because of that, you know, our body is being put into different positions and doesn't have the support that it usually does. So it's really common to have pain in areas. So we can address that. Then postpartum, again, your body has gone through so much and now you have pushed a baby out or had a cesarean section. So there is a lot of things that can happen because of that. So we treat everything postpartumly as well. And you can go to the next piece.
All right. What pelvic floor PTs assess? Pretty much the same as any other PT. We have a few little pieces that are different. We go over posture to see how the rib cage is stacked over the pelvis throughout the whole chain to give us some ideas of, you know, where things might be breaking down. Joint mobility with particular attention to the low back, the SI joint, and the hips. You'll see a theme here with the regions that we like to focus on. Muscle flexibility, again, hip muscles, pelvic floor muscles. This is where we will differ from a regular orthopedic PT, where we can assess the pelvic floor muscles both internally and externally, depending on what is indicated. Muscle strength, again, we're looking at strength of the abdominals, hip muscles, and again, particular attention to what the pelvic floor muscle group is doing. Muscle coordination too, again, pelvic floor, lower abs, glutes, making sure they are firing in the right pattern at the right time, in the right form and function for what you're trying to do. All right, now getting a little more into depth with some of these diagnoses. So we'll start with urinary incontinence with some definitions. Stress urinary incontinence is the involuntary loss of urine with physical exertion. So physical stress, not emotional stress, although that can play into plenty of symptoms. But we're talking about coughing, laughing, sneezing, running, jumping, anything with impact that will increase the pressure and urine might leak out. Urge urinary incontinence is involuntary loss of urine associated with a sudden and strong urge to urinate. It is not just the gradual buildup, it is all of a sudden, I have to go, this is very urgent, if I don't go, there will be a problem, or there is a problem. Mixed is a combination of both stress and urge. So treating urinary incontinence, we do a lot of education on anatomy, as you saw the pelvic floor muscles in the first slide. Behavioral techniques, we do bladder diaries to see where we can help you with some bladder retraining. There are urge suppression techniques. Diet and hydration is important. A lot of people will start to limit their liquid intake, and we want to promote adequate hydration as well as proper diet to keep bladder irritants out. Stretching and strengthening with what we find in our evaluation. Kegels, not for everyone. If the weakness is the source of leading to the incontinence, we will do Kegels. However, if the muscle resting tone is too high, increasing the pressure in the pelvic cavity already, it is not a good idea to do Kegels because one, the muscles are not going to move very far, but two, their resting tone is so high that they're pushing urine out. So we need to work on relaxing those muscles and lengthening those muscles first. All right, some stats on urinary incontinence just to show some of the importance. It affects about 25 million adults in America. And a quarter of women between about ages 20 and 60 have involuntary leakage. Another point, even though this is from 1990, that is quite interesting, is almost 300 regular exercising women were surveyed, and about half of them have reported an instance of urinary incontinence. This Cochrane review here went over 31 studies with almost 2,000 participants spanning several countries. And the biggest thing is that women who got pelvic floor PT versus no treatment reported that they were 5 to 8 more times likely to be cured, which is a big impact. And one of the studies also showed that there is promising economic impact with some cost effectiveness with pelvic floor PT. It's relatively, it's a conservative treatment and inexpensive compared to other medical treatments. Pelvic pain. Elena went over some of these before. Chronic pelvic pain is pain anywhere in through the pelvis that has lasted greater than 3 months. IC and BPS, interstitial cystitis or painful bladder syndrome, same name, one name for 2 different things. A chronic condition, so this falls under the umbrella of chronic pelvic pain, causing pressure or pain in through the bladder, as well as like suprapubically or even in through the pelvis and the perineal region. Vulvodynia is pain of the vulva, which is the area around and outside of the vagina. That can be chronic or it can be acute. Vaginismus is an involuntary contraction or tensing of the muscles around the vagina upon insertion. So that could be a tampon, during an exam, during intercourse. And as Elena touched on earlier, dyspareunia is pain during intercourse and particularly pain with penetration. How to treat pelvic pain. Again, you'll see the diet modifications under there. It's a theme throughout the presentation. Vaginal dilators are helpful for some patients to allow them to tolerate that penetration. Stretching and relaxation techniques, again, allowing pelvic floor muscles to lengthen if they need to, as well as hip muscles, abdominal muscles, legs, based on what we find in our evaluation. And finally, postural modifications and functional training. What are the individual goals of our patient? What is important in their daily life? And what do we need to get you back to? So making sure squatting mechanics are appropriate so that you're not feeding into these patterns that will continually put more and more stress in through the pelvis and the pelvic floor.
I'm going to talk about pelvic organ prolapse. So this was on the overview slide where there was all those weird words, cystocele, rectocele. So basically a pelvic organ prolapse is when the pelvic muscles and tissues are no longer able to support the pelvic organs. So this is where you have that drop or prolapse of the organs. So I like this picture right here on the right. You can see on the left is that yellow, that's the bladder. So that's the most front part of your body. Then in the middle, you have the uterus. And then in behind on the right is then that brown, which is the rectum. So when you're looking here, you can see there's that kind of mesh or a hammock. That's what the pelvic floor is. So what happens is, so with the cystocele, essentially that bladder starts to come down and bulge and protrude into the anterior or front portion of the vaginal wall. With a rectocele, that's where you have the rectum that bulges or drops down into the posterior vaginal wall. And then you have the uterine prolapse, which is right in the middle of that pink. That's where you have the uterus that kind of starts to drop down directly into the vaginal canal. So that's just 3 of them, but there are multiple others, such as a urethrocoele, which is where your urethra, which is where your urine comes out, that can actually protrude into the anterior front wall of the vagina. And then you also have an enterocoele, which is where basically your small intestine can protrude into the posterior part of your vaginal wall. So essentially what happens is that you feel this vaginal bulging, pelvic pressure, you can get some low backache, bleeding, things like that. And then when you go into that gravity reduced position, such as lying down, or if your hips are up above your heart or your legs are up above your heart, then you start to feel reduction in that pressure. So with that pelvic floor, if you have too much pressure going down, or the pelvic floor just isn't strong enough, then you can get some of that drop down. Next, please. All right, so treating this then, we'll talk a little bit about constipation and toileting strategies in the next couple of slides, but that can be a big piece to cause pelvic organ prolapse. So that's one of the things that we want to make sure that we are addressing, as well as pelvic floor strengthening, postural education and body mechanics, and then stabilization exercises. So this is where we'll talk more about constipation. So bowel dysfunction, there are 3 kind of overview areas that we'll talk about. So there's fecal incontinence, which is where you have leakage of the feces, constipation, which is where you have difficulty defecating or having a bowel movement. And then there is dysenergia. So dysenergia is essentially just where the nerves and the muscles are not able to work properly and coordinate together to have a normal bowel movement. And as a general overview, you have a typical bowel movement of 3 times a day, down to 3 times a week. So anywhere in there is normal. And then outside of that is where you start to get, okay, we need to talk more about it. Go to the next slide. So my patients will tell you, I love the Bristol stool chart. I think it is great. I think it should be in every bathroom. So it's really great because as a picture here, you can see type 3, type 4, those are normal. So basically that means you're having good fiber in your diet, you're drinking enough water, things like that. If you have type 1 or type 2, that means that we need to start to soften the stools up. Type 5 to 7, that's where we need to make sure that we're bulking the stools up more. So trying to stick within that 3 to 4 range is the normal. So looking at treating bowel dysfunction, diet and hydration is going to be key. So we talked a little bit about bulking versus not. So with making sure you have enough hydration, you want to think about taking your body weight, divide it in 2, and that's the number of ounces of water that you should be drinking a day. Also with your diet, making sure you have enough fiber and alternating it to different pieces of it to make sure that that's improving. And then pelvic floor muscle strengthening versus lengthening. So this is where what Maureen was talking about earlier, where, Kegels aren't always the best thing depending on the person. So it can be, okay, I'm having fecal incontinence because my pelvic floor muscles just aren't strong enough, or they're too tight, and then you start to have some leaking out. So there's a number of different things. Same with constipation. Oftentimes that muscle can be just too tight and not allowing you to fully release. Then looking here at toilet positioning. So you can see on the right here, there is a picture of what we don't recommend and then what we do recommend. So if you've ever heard of a squatty potty, that's what the feet, that blue thing is that the person's feet are on. So basically your knees should be above your hips and then lean forward. This actually, as you can see, allows that muscle, your puborectalis, which is one of the muscles in the pelvic floor, allows it to relax so that that rectum is not being pulled on, or it says in here, or choked along the tissue, so that you can have a good bowel movement and a release. Time voiding is also a nice thing too. I like to call this adult potty training, because basically what can happen is that you get into this groove of, every time before I leave the house, I have to use the restroom. Or every time the water goes on, I have to go to the bathroom, things like that. So we want to make sure that we kind of get you back into a rhythm and work with retraining the body and the mind to be able to get into back into the regular rhythm. And just making sure too that throughout your breathing, because by really holding your breath, especially when you're going to the restroom, is going to put a lot of pressure and not allow you to have a full relaxation. And next.
All right, what to expect from pelvic floor PT? At an evaluation, we will take range of motion measurements, back, hip, knee if needed, strength measurements, again, pelvic floor, abdominals, hips, posture assessment, movement pattern assessment through how do you get up in and out of a chair, lying down, sitting up, squatting mechanics, internal pelvic floor muscle assessment to test the muscles individually for any tender spots, any tightness, as well as assessing for pelvic organ prolapse if indicated, and strength test. We will also do abdominal wall assessment to feel how the muscles are contracting. We can assess for a diastasis through the center of the abdominal wall. And also we'll look at the angle of the rib cage to see if there's any rib flaring either forward or sideways as well. That gives us some indication on either lack of muscular activation or gripping and too much activation. So we can help to get all the muscles on firing at the appropriate times. As far as treatment, education is big. We're both really big on that and helping our patients understand, one, what is going on, and two, what you can do to help yourself. You're only in PT for an hour or two a week, maybe sometimes 3, but it's really more of the time you spend on your own. So we like to empower our patients with a lot of education. Manual therapy for the regions that we identify at our evaluation, whether it be pelvic floor muscles, the hips, the back, the abdomen. Again, flexibility and mobility exercises based on what we find in our evaluation, as well as strengthening exercises for the necessary muscles. Something of note that a study has shown that less than 25% of women completing pelvic floor strengthening or Kegels are doing them correctly. So a lot of people, that's almost 75%, are not quite getting the benefit they think they're getting. So it is great to have someone check to make sure that you are getting an effective and appropriate contraction so that you know the energy you're giving is worthwhile and helping you achieve your goals. Finally, functional exercise, as we have touched on before. If you need to be able to get up and down from the floor, we will work on those transfers on and off of the toilet, in and out of the bed safely, especially for our patients who are pregnant or recently postpartum to help promote healing. But of course, anyone with low back pain or other orthopedic concerns, as well as running, really patient dependent.
So here looking at treating pregnant and postpartum patients. For pregnancy, when patients are coming in, we're really looking at their posture, especially because as you can see on this picture on the bottom, as the baby grows, it really causes that increased lordosis, or that curve in that low spine, which can really cause some of that low back pain if not treated properly with strengthening, abdominals, hips, making sure that you're able to be nice and coordinated. Also just task modification for safe movement patterns. So with this, we're looking at, lifting, squatting, being able to, if you have another child, picking up the child and doing it safely, making sure that you feel safe exercising, because during pregnancy, exercise is so important. And through core strengthening, you can reduce your risk of diastasis recti, which is where you have a separation of the abdominal wall. Another thing too is education. So as Maureen said earlier, we love to educate. It's really important. We can talk about labor positioning, ways to reduce your risk of tearing, and just ways to make sure that you have a faster recovery after birth. And then that goes into that postpartum piece, which is where we want to make sure that we're modifying movement patterns to make sure that you're healing properly and effectively. And then abdominal activation for preventing diastasis or treating it as well. And then making sure we're working on strengthening, pelvic floor, either activation or lengthening, kind of depending on what's going on as well. One of the things I like to do too with postpartum patients is lifting mechanics, from lifting patients, having them lift their babies from a crib, from the ground, different things like that, because that is something that as the baby grows and your body has changed, you want to make sure that you're doing this properly, especially because the baby's only going to get heavier as it grows. So here's something, this is a really nice pelvic floor dysfunction screening tool. So we have a link on this. I will actually, do you think you can open it up for me?
Yeah, I can try to see. It should
okay.
Work.
Perfect. So this is a nice screening tool. We can see about if we can send it possibly to the emails of everyone who's signed up. We'll try and think of a way to get it out to you guys. But essentially,
a form that we could send out.
Okay. Yeah. Yes, perfect. We will send the form out. So this is a nice way where it was actually identified 91% of people with pelvic floor dysfunction. So when you're looking at this, essentially, if you check 3 things or more on this pelvic floor screening, then you are at a really high likelihood of being a patient for pelvic floor therapy, and that it would be effective for you. So I won't go through all of them because I'll send it out so you can take a look, but it's just a nice tool to screen in case you were wondering. Yes, perfect. Rita, we can make sure that we will send you that email information. I just saw we had a note.
Chat, yes. Okay, that is the end of our presentation. We want to make sure that you guys know and pass along to anyone else in your office or your family, friends, that you can schedule a complimentary virtual consultation with either of us, depending on really which location you would potentially be going to. I'm at Lakeview and Elena is in the Loop. But we want to make sure that if there's anything specific you want to discuss to see if you are a candidate and if it would be appropriate timing for you to come to physical therapy, that we would be happy to do so.
Yes, I'm just looking here. We have a message. Yes, you may stay on longer. Yeah, if anyone has questions, feel free to stay on and ask them. But thank you guys so much for coming, and we appreciate it. We love talking pelvic floors, so anytime that we're able to spread the word about it and get everyone to, understand their body and see kind of what's going on, we love it. So
yes, we do. These are our references just to show them so that you know where we got some of our information.